If you feel like something is broken and you feel it inside of you, in our hospitals, in our food, in our leaders, even deep within our souls. They told us medicine was about healing, but somewhere along the way, it became about profit. They told us science was about truth, but now it bends to whoever can buy it. They told us technology would free us, but it's being used to control us. I'm Dr. Joseph Miladore. I'm with Dr. Anthony Fossaceca. We're going to be discussing how we've seen sickness in our systems, and we're not sure what the cure is. But it starts with truth. It starts with courage. It starts with remembering that every human being is sacred. Here, we're going to try to expose the corruption. We're going to try to honor the sacred. And we're going to try to use technology as it was meant to be, to lift people up and not tear them down. We're going to try to amplify the signal of those of us still brave enough to care. This isn't just an episode today. We're hoping that it's a start of a movement. And if you're tuning in, we're hoping you could be a part of that movement for us. So with that, Anthony, I'm going to turn it over to you. Today, we're going to be tackling PBMs. I'm going to let you kind of introduce what that means and how the system, in terms of medication production and then sale, goes into effect.
Sure. So just before that, I want to just say that my name's Anthony Fossaceca. I'm a pharmacist. I've been a pharmacist for 10 years, I have a wife and 2 kids. One of the things about PBMs that gets close to heart is because I had an independent pharmacy with my father. So first off, what is a PBM? PBM stands for Prescription Benefit Manager. What a prescription benefit manager does, in simple terms, is they are a middleman between the health insurance company and the pharmacy. They handle claims when it comes to taking money from the insurance company, paying the pharmacy, and they also decide what's on formulary. We'll get into all that and even what formulary is here shortly.
So with that, we're just going to talk about a few different things to start off with. First, you have the manufacturer. The manufacturer is the company that invents and produces the drug. Examples of these are Pfizer, Eli Lilly, and Novo Nordisk. They generate the sticker price. I use the term sticker price because we can all relate to that. That's like the price that you would see on a car in a car lot. Then you have the wholesalers. These are the big distributors. Think of these people as the ones that store the medicine and deliver it to the pharmacies. They're like your Amazon warehouse. These are McKesson, Cardinal Health, AmSource, Bergen. Then you have the pharmacy benefit manager. The 3 main pharmacy benefit managers that Anthony's going to get into: CVS Caremark, OptumRx, and Express Scripts. The PBM essentially negotiates with the manufacturer for a rebate in exchange for putting certain drugs on their formulary. What is a rebate? A rebate is a percentage of money that goes from the wholesaler to the PBM. Essentially, in my opinion, a bribe. A bribe for that specific medicine to get put on a formulary so that way that medication is available to patients for purchase and or prescription. Then you have the insurance company, which we're going to get into this, but these same insurance companies are owned by the same companies that own the PBMs. And the insurance company decides what portion of the drug's cost they will pay and what portions of the drug cost you will pay. And then, of course, we have the pharmacy. Now, retail pharmacies like CVS and Walgreens are mail order. They get all of the drugs from the wholesaler. They pay a bill to your insurance, from what I understand. And they also collect your copay. Now, so with that, I'm going to turn it back over to Anthony because he's going to discuss the intricacies of how these 5 entities interact.
So, like my friend Dr. Miladore said here, the 3 main PBMs are CVS Caremark, OptumRx, which is owned by United Healthcare, and Express Scripts. Now, these 3 PBMs are responsible, they touch 80% of all the prescriptions in the United States. So, in 2023, that number was 6.6 billion. That's how many prescriptions were filled. So they have their hands in 80% of those. Now, just to kind of go over a little bit more of PBMs of what they are. I like things laid out in examples. That's the easiest way for me to understand things. So that's what I like to do. So the way that it works here is we listed a few drug manufacturers. I'm going to go with Eli Lilly and Johnson & Johnson. Eli Lilly makes a drug called Jardiance. Johnson & Johnson makes a drug called Invokana. These are both diabetes medications, are both in the same class of medications. That's why I'm using these two specifically.
Can you explain why it's important in this example, why they're in the same drug class so everybody understands?
Sure. Sometimes in when new studies come out, these two particular drugs are a relatively new class of medication. So we're still learning a lot about them. But when studies come out, sometimes we will find that one drug in a particular class is better at treating something or shows less adverse effects than the other drug. So we develop guidelines based upon those studies and that data. Now, I'm not saying in this specific example that one of these drugs is better than the other. Just to keep it easy and layman's terms, I just wanted to kind of lay out one versus the other.
So basically what we're saying, if we have a clinical situation for multiple patients, these two are options for the physician to pick which medication that we're going to prescribe.
Right. Exactly. So now, again, these are the manufacturers of the drugs, the Eli Lilly and Johnson & Johnson. So the PBM, let's use Express Scripts for an example, or CVS Caremark, because they have a pharmacy. It's the easiest way to try to see all this happening. So CVS Caremark goes to Eli Lilly and Johnson & Johnson. Do you want your drug to be on our formulary? So formulary is, in layman's terms, just a list of drugs they're going to fill, but they're going to pay for. So in order for one of these medications to be on formulary, they'll have to cut a rebate check back to the PBM. So what that looks like is they're going to look at which one of these is going to give them a bigger chunk of money. Let's say Jardiance comes forward, Eli Lilly, and says, we'll give you $50 every time a prescription is filled. Johnson & Johnson says $35. Well, guess what? Jardiance is on formulary. So now we have the PBM telling your doctor what you can have.
When doctors look up things, they use mainly a database called UpToDate. Just so everybody knows, UpToDate is the Wikipedia for medicine for physicians once you become an attending. An attending means you've essentially done all your training and now you're ready to go out and practice. This can easily be manipulated to where the UpToDate guidelines can tell a provider what medication to pick, what would be best for this patient to get the best outcome and have the least side effects. But we, as the provider, may not be able to pick this medication simply because, not because it costs too much to produce, but because they didn't offer enough money, they meaning the manufacturer, to the PBM to get this medication on the list of medications that are able to be prescribed. That's why this is a big deal. And the sickening part is because it's all for profit. Sorry, go ahead.
Please interject. So the reason PBMs exist in the first place is they claim to control drug costs. So everybody, I think, had to relate to that. In the United States, we spend so much money on medications that I think it's pretty much a bipartisan issue across the aisle. We want to control drug costs. So it sounds good on paper. In reality, the only thing they do with those controls is they put them right in the pocket. So let's say we, in this specific example with this rebate, you think any of that rebate goes to the patient?
No, I would say none of it.
And also none of it goes to a lot of times an employer will hire a PBM to handle the drug that. So they employ 10,000 employees. And let's use when GM is, for example, they used, I believe it was Express Scripts. So an employer decides, okay, we're going to pay you for Revit. And every time we one of our people fill a prescription, you're going to tell us what it costs and we pay you. You think the employer sees any of that rebate money?
Absolutely.
No. And on top of that, it can actually make it more expensive for the patient because in certain examples, it's not even the cheapest drug, but it's the one with the biggest rebate. So if you have a high copay or co-insurance, you're paying a big portion of what it is. And the PBM is just sitting there really collecting money from all the sources.
And also what I want to emphasize is the reason why it may also cost you more, in addition to the rebate kickbacks being involved with that, obviously we understand that the manufacturer is going to offer the PBM X amount of dollars, and then that drug also costs X amount of dollars to produce. We all get that. But on the flip side, once we get into how there's this vertical integration where the pharmacies are owned by the same parent company, the PBM's owned by the same parent company, and the insurance company is owned by the same parent company, guess what? Those same parent companies are setting the price that the patient's going to pay out of pocket for those medications at the pharmacy, and they're collecting your copay for more profit. So they're profiting on 4 different levels.
This is only one way how they make money, is that the rebates. When you look at this just isolated, it seems like they would make a lot of money in itself. But another way that they make money is what we call the spread price. So to make it simple, the spread price is the difference when the PBM goes to your insurance and says, oh, you got Blue Cross Blue Shield. Dr. Miladore, Joe, you're going to fill an omeprazole. That'll cost $50. They turn around to the pharmacy and they go, here's $20. That difference there is $30. That's the spread. But I'm going to use the jargon's example to make it easy because we were talking about that before, just to kind of keep the numbers consistent. So you go to your doctor. Your doctor says, I want you to be on Enbocon. You go to the pharmacy. Pharmacy says, oh, it's not on formula. Now your doctor switches you to Jardiance. You go back to the pharmacy. You realize, okay, I have a $50 copay on this medication. You're paying $50. That's not, you're paying pharmacy $50. The pharmacy pays for the medication from the manufacturer. Where this drug might cost the pharmacy 30-day supply. Let's say Jardiance costs $450 from the pharmacy, because a lot of times these brand name medications are very expensive for the pharmacist. The PBM will tell the pharmacy, we collected, well, they're not going to tell the pharmacy what they collected from the insurance company. They're going to say, okay, this costs you $450. You're going to get paid $430 total. We're going to pay you $400. The patient's going to have a $30 copay. Now, obviously, you can't stay in business as a pharmacy losing $20 every time prescriptions go. But when you look at what the PBM has made now, let's say that they told the drug cover themselves. They told the insurance company this was $500. They charged them $500. They pay me for it. So now they've made $100 on the spread, and they've still made that rebate, whatever that is, from the manufacturer. So both now they're $130 on prescription fill. Patient is out, $50, whatever we said. The pharmacy loses $20. The only people making money in this is the PBM. And Eli Lilly isn't going to take it on the chin with these rebates. They just jack the price up of their drug. Again, about passing it down to the patient and the providers. So that's 2 different ways now PBM is making money. Spread and the rebates. So go ahead, Sophie.
I was just going to ask, in terms of clinical benefit, what do the PBMs offer to the United States healthcare system?
Literally nothing. They offer zero. They're only there to pull money out of healthcare and make massive profits, because they do make massive profits.
Why do we think, as a former pharmacy owner, why do we think this continues to happen? If you had to put on your conspiratorial hat and give your own opinion about why this is allowed to occur, what do you think?
I mean, lobby. They crank money directly into politics, where on the surface, this looks like it should be a no-brainer. But unfortunately, they crank so much money into Washington, D.C., that real PBM reform never happens.
So I actually have the numbers up on lobbying. And since you mentioned that, I kind of want to go there right now. So the 3 parent companies of the big 3 PBM, like Anthony mentioned earlier, 3 of the companies own 80% of whole market share of the PBMs. Of those 3 parent companies, and Anthony, please correct me if I'm wrong, we have CVS Health, United Health Group, and Cigna. Those 3 parent companies own the 3 different PBMs that we just discussed, plus they own the insurance company affiliated with them, and also a lot of them own their own big-time pharmacies now as well. But CVS Health, the parent company of that, over the past 5 years, lobbied $40 million, approximately, just to the federal government. United Healthcare lobbied $30 to $35 million to the federal government over the past 5 years, and Cigna lobbied $40 to $50 million to both federal and state over the past 5 years. That is the main reason why this is happening. I want to emphasize that. you can attack lobbying, and almost everything that negatively is happening in healthcare right now is because of what's going on in Washington, D.C., and the reason why there's no change. Essentially, these companies are paying off Congress, they're paying off the White House to not make any changes, to continue to manipulate the patient and continue to make a profit off the patient, which is, to me, insane. Do you have any other numbers that would support that data?
Oh, I mean, I have. So what you're talking about is vertical integration, like we call in pharmacy, the PBMs, the insurance companies, PBMs, and the pharmacies. It's all owned by the same entity. And obviously that brings about a lot of, red flags. Unfortunately, it also brings about a lot of fraud because you have regular people, and I'm not excusing fraud in any way. It's not okay. But you have regular people who are trying to do their job who can't make ends meet because they're being so tight to reimbursed by these entities. And again, I would never say fraud's okay, but you can almost say that it's fraud to ask a healthcare professional to, take on the liability of filling a prescription, to counsel the patient, to buy the medication, all the software, all the training, and pay them less than the drug cost because you want to fuck. In my opinion, you can consider that wrong. So I'm not excusing the practitioners that do commit fraud. I'm just saying an environment like this opens up the opportunity because people are being squeezed so tight.
And then you take it one step further, and we're going to talk about this in subsequent podcasts. I'm not even sure if science is science anymore. And the reason why I say that is because the same people that are quote unquote doing the science, doing the studies, are the same people that own these big three companies. So of course they're going to push their product and bully their product onto the front line. So to me, everything about this is corrupt, and it's total system capture from top to bottom. And I don't think that these big three companies are going to stop here. I think these big three companies are going to try to start buying physicians directly.
Wouldn't surprise me at all.
Because you look at the trend, right? You look at the trend, physicians used to be independent practice. They were heavily independent practice in the 70s and 80s and 90s, and then there was a switch. Why? Because physicians don't get taught how to run a business. Just like in pharmacy school, please correct me if I'm wrong, I don't think you guys get taught how to run a business. We have to figure that out from ourselves. We just get taught the science. And a lot of physicians don't want to do that. A lot of pharmacists don't want to do that. So what do? They join, in the physician's case, hospital, big hospital. In pharmacist's case, they join one of these big three companies just because they don't want to have to deal with running a business. Take that one step further. What if eventually the hospitals say, we don't want to deal with running the business anymore? We don't want to take the risk of having to shut our hospital system down. What if the rural hospitals said that? What if these big three parent companies came in and started buying up all the rural hospitals in a particular state? And then all of a sudden, they can say to the actual providers, we're the ones writing your check. Now you definitely have to prescribe this drug, and you definitely have to tell this patient which pharmacy they can go to. I don't see that being that far of a leap. And I think that's the next step in terms of the money grab. If they're going to grow their assets, they have to keep going down the food chain because they've already devoured everything that they can in this particular point. And we'll get into the numbers in a second, but they've already have 80% of monopoly on the PBMs. They already have shut down multiple independent pharmacies and other smaller pharmacy companies. And there's basically now just several different major pharmacies left in the United States. The next step is essentially creating the last variable of the providers into one giant pot, which is totally plausible in all of this. It's just one step away.
Because they're not going to stop growing. They're not going to say, "Oh, we're good. We're satisfied here. We're just gonna pull it and ride it out." That's not the way this works. They're going to keep going. You're right. They are. That's the next step. That's why they now in the insurance companies. And we talked about before. Your doctor can now tell you, "But you have Aetna insurance." Same people out of Aetna, CVS Caremark, but CVS. So you have Aetna, but you can't see Dr. Middlemen. We've got to go see this guy. So now they tell you who you can go to. Now they tell your doctor also what they can write. And then they turn around and go, oh, but your drug plan, you have to use mandatory mail order. You can't go to these pharmacies that you normally go. The pharmacist said, look, that knows you, knows your family, knows what you're filling, and has an item. You can't go fill with him. You have to get it dropped off to the mail, which that's a whole nother thing for another episode of mail order pharmacy. But now they're telling you what doctor you can go to, telling the doctor what they can write. Now they're telling you where you can actually get that.
which is all insane. And let's get into the numbers a little bit so people can understand en masse what we're talking about and why this is such a huge deal. When I did my research, in terms of assets, CVS Caremark itself is worth $253 billion. OptumRx is worth $298 billion. Express Scripts, as of 2017, that's the most recent data that I have, was worth $54 billion. So I'm sure it's growing since then astronomically. In 2024, CVS Caremark, their net profit was $4.6 billion.
Yeah, in 2023, the PBMs profited $21.5 billion together.
And OptumRx was $14.4 billion profit in 2024. Express Scripts was $4.5 billion as of 2017. I couldn't find the data all for 2024, but these are insane numbers. We wonder why healthcare costs so much. We're looking right at it.
Yeah, and they're not only giant profits, they're squeezing other people out of competition. It's been shown and proved that these PBMs, Caremark pays CVS different than it pays my pharmacy. So you can have a prescription for omeprazole, they pay them different than they pay me. The mail order reimbursements are wildly different. And you see what they charge your insurance company. As somebody who knows what omeprazole costs from wholesaler, if you paid me like they got paid through the mail, I would be driving around on a yacht with the prescription volume that we fill, because it's not even the same ballpark. And they do that because they're the only ones with the mail order pharmacy.
And so another thing that is driving this to a high degree is what these companies do with their profits. I just want to throw a number out there. The CEO of CVS Health, the other numbers were not made public for the CEOs at that time. The CEO of CVS Health in 2024 made $17.8 million. Why did he do that? Well, he bonused around $15 million because of the profits that he brought in. Who did the profits go to? They go to the shareholders. Shareholders are greedy. They want more money per share. So what do these companies do? Well, these companies then go back and buy as many shares that the current shareholders are willing to sell. Why? Because then that means that when you have dividends, you get more of the percentage per dividend per person. So they literally just take the profits to reinvest to buy back the shares as the company, so that way then their current shareholders that they want to have all the money go to get even more money from it.
You're spot on, Ben. I mean, and people might be wondering, like, why isn't this a bigger thing? Why isn't this thing new? I think that's intentional, that the normal person, everyday person, does not know what PBM is, because they don't want you to know. They don't want you to know this.
It's exactly what you're talking about. And let's talk about this just a little bit further. Let's go a little bit deeper. And this may get a little conspiratorial, but I think it's the truth. When you look at the top investors, because remember, these are all publicly owned companies. The top 3 investors of each of these 3 parent companies are BlackRock, Vanguard, and State Street. When you look at the different industries, let's talk about media for a second. Who do you think are the top 3 investors of Fox News and CNN? BlackRock, Vanguard, State Street. When we talk about food, maybe in our next podcast, who do you think are the top 3 investors in the top 3 biggest food companies in the United States? BlackRock, Vanguard, State Street. So the same people that own those 3 companies also own the media and also own the parent companies for what we're discussing. Of course, we're not going to hear about it. Of course, we're not going to hear about it. Oh, and by the way, those same three companies, when we talk about those lobbying numbers, who the hell knows what BlackRock, Vanguard, and State Street actually are lobbying because they have their hands in everything. They're the ones pulling the strings. They don't want us to know about it.
Well, I will say, on a positive note, the Federal Trade Commission is investigating this. They've filed a lawsuit. It's been ongoing for a couple of years to get data, but they're starting to come out with some of that data, and I think people would be very interested in it. So the lawsuit shows flat out PBMs increase costs for patients and employers. And the reason I said employers is like we mentioned with GM before, they pay a PBM to manage the drug debt. So this study is showing the full reason PBMs exist are to control drug costs. This study shows they actually do the opposite of that. So if they're doing the opposite of that, that flat out means they're pocketing the extra money. So they also mark up meds, the study has shown, dispensed by their own pharmacists. A lot of these were specialty medications, which we call those are medications for cancer, HIV, and a bunch of other chronic conditions. So the report showed that 63% of specialty generics dispensed by PBM-owned pharmacies were marked up more than 100%. 63% of the medications. I'll go even further than that. 22% of drugs dispensed in this were marked up over 1,000%. So these specialty medications, they tell the patients, you got to go to our specialty pharmacy, and they mark it up 1,000%.
And this is total, and I'm getting really frustrated here because we want to talk about real world examples. I had a patient earlier today talk to me about their Eliquis cost. So I'm not going to get into what a 340B program is. Just in quick summary, it's essentially a program that helps reduce costs for patients for expensive medications. And this was available at East Liverpool in Ohio. And that program recently shut down. So now I have a lot of patients that were relying on that now have to go to their regular pharmacy to get medications filled. Eliquis, just so everybody knows, Eliquis is an anticoagulation medication that is used for patients with atrial fibrillation to prevent stroke and death. Their cost went from the 340B program at being $20 per month to $770 per month. How does that happen? It happens by what we're talking about, which is totally ridiculous. You want to talk about real life examples? That's what you just said, the marked up price. These companies know that Eliquis has good data in terms of decreased side effects with no GI bleeding and no brain bleeding, and it decreases risk of stroke. So what do? They jack up the price, and they make you as the patient feel guilty about buying an inferior product that has more side effects that may cost less. And they make physicians feel guilty for prescribing it, or they just don't allow it.
Right. And to go even a step further with this, we talked about the rebate from manufacturers to the PBM. In 2023, the total amount spent from biopharmaceutical companies that went to PBMs in 2023, again, just manufacturer, PBM, $170 billion in 1 year. So everybody wants to blame the drug companies, and I'm not going to say that they don't play a part in it, but that's how much the drug companies had to pay to PBMs just to be in the mix.
$170 billion bribe.
In 1 year. So I have some more numbers here for you. 25%.
With paying $170 billion if they can't afford it though.
Right.
So the astronomical numbers that we're talking about here is totally laughable. But I'm sorry, go ahead.
No, it's hard to even wrap your brain around numbers like that. Like it's hard to visualize. But when you look at all money spent on brand name medication in the country, 25% of that money goes to PBMs. Not the manufacturers, not the healthcare practitioners. 1/4 every dollar spent on a brand name medication is a PBM pocket.
That's just ridiculous because they don't do anything for anybody. They don't add any value.
And this is specifically the brand name. When they're in the patent window, the company that invented the drug is supposed to make their money on it and make their profit. The PBM at this point is taking 25%. When you look at generics, the studies show they take about 80% of all money spent on generic. to go even further, we talked about, patients, when it comes to those rebates, the patients being any better. The patient's copays are all based on the pre-discount. The patients see all the calculations are after all the rebates, after all that stuff.
It's just so disheartening because I come from a family full of physicians, and I take great, great pride in my work. I mean, I give 150% every day, and by no means am I perfect. I don't need some bullshit going on behind the scenes that is making my job more difficult when I'm already a human being and I'm prone to mistakes. I mean, this is just unacceptable. And for what? What are we selling our souls to?
Right.
I mean, what is the end game here? When is enough enough? And the only way that the tide is going to turn is if we keep talking about it, if we keep bringing it to everybody's attention, and if we, and when I say we, I mean the collective we, all of the patients, because I'm a patient too, stand up for ourselves. Otherwise, BlackRock, Vanguard, State Street, because those are the real players here. They're going to keep pulling the strings because nobody's checking them because they keep paying the congressmen and people in Washington, D.C.
I mean, these guys have just generated a formula to rob the American public of healthcare dollars, and just it's almost like people don't care because they don't even know.
It's, to be honest, I tip my cap to them. It's genius.
Pull it off, yes.
And on top of that, it doesn't work like this in other countries around the world.
No.
So the fact that they have the American public not realizing what's happening, that we're in a unique situation and robbing us of $170 billion per year at least, is truly mind-blowing. I want to put that number into context. The Big Beautiful Bill, just real quick. The Big Beautiful Bill is cutting $10 trillion to Medicaid over the next 10 years. Now, that's going to hurt rural hospital systems because most patients with Medicaid, underserved, go to rural hospitals. Now, the government is giving those rural hospital systems, divvied up appropriately, $50 billion to try to offset that. So you mean to tell me that we're going to cut the most underserved patient population $10 trillion, and we're only going to give the rural hospital system $50 billion to make up for that cost, but yet there's enough money in the healthcare system to allow the PBMs to be paid $170 billion per year.
Just from the guys who are the ones making the medication.
Doesn't even account for spread costs.
Yeah.
Doesn't account for if they own the pharmacy, your copay. It's just sickening to the point where we are allowing our underserved community to simply not get healthcare so people can profit.
But it's a theme here. Like if you've ever seen those copay cards that people get with Eliquis stuff, where you can't use it with government insurance, but your copay no more than $40 to cover a certain chunk. So those are the manufacturers of the drug that are providing assistance to help people with these costs. So that's one way they do it. That in 2023, there were roughly $23 billion spent by drug companies to cover this assistance. Guess how much of that money went directly to PBMs?
I'm going to guess at least 50%.
Well, about $5 billion. So not quite 50%, but $5 billion in money that is there, that is the drug companies saying, hey, our drug's too expensive. We're going to help people afford it. $5 billion of that went directly to the PBMs.
It's just unacceptable.
It doesn't make sense.
It's the exact opposite of why I became a United States physician. I mean, I wanted to do anything that I can truly in my heart to help people. And people want to call me out and saying, I'm just saying that because I'm sitting here on a podcast. That's fine. Come talk to me. Come see me in the clinic. Come see what you think. I'm open to interpretation. I'm also open to feedback. That's not what this is about. I did not go through all of this, and I know you didn't either, to essentially be a part of a system to where if I stay silent, the underserved community gets screwed every single step of the way. And by the way, not just the underserved community, we all do, but we feel it to a lesser degree because we have the finances to be able to still survive
Sure.
and get our medication. But we're still getting screwed too. Just because we can afford it doesn't mean that we're not getting screwed out of some of this.
We're also being squeezed on the reimbursement side so hard, and I don't want to harp on that too hard, but the reason that I mentioned that is it's stressing practitioners out so much that they're making mistakes because they have to work at a very stressful pace and a lot of hours just to maintain, essentially to take care of each.
Let's talk about that for a second. Let's just go on that for a second, and then I want to hear about the reciprocal version of this, which is the pharmacy side of this version as well, because I think that's also important. But on the physician side, so what is Anthony referring to? He's talking about how in certain insurance companies, when you're on their formulary, when I'm talking about a medication, let's say if a physician wants to prescribe a medication that's not on formulary, what do they have to do? Well, they have to fill out a mountain of paperwork. It is that simple. The insurance companies try to blind the provider in paperwork and their staff in paperwork to get you to say, you know what? Screw it. We're just going to prescribe the one that's on formulary, even if it doesn't work as well and has more side effects and isn't as good for the patient and it costs more.
Even if you didn't get frustrated, it'd take 2 weeks to get all that paperwork done if the patient can't get the med.
100%. And sometimes, not all the time, but sometimes the questions that the prior auth requires, because if you have a prior authorization, it's different for each drug. They ask you specific questions in regards to that clinical scenario. Some of those questions are total bogus. Let me give you an example. Let's talk about Mounjaro for a second. Mounjaro, one of the first questions they're going to ask is, what's the patient's hemoglobin A1C? And if it's not above 6.5, you can't get the medication covered even if you are 400 pounds. What does that tell me? That tells me that this big conglomerate doesn't care if you develop chronic disease. In fact, they want you to, so that way you get boxed into needing to use their drug for forever. They don't want you to get healthy and lose weight to prevent you from getting diabetes. Let me give you another example about the GLP-1s that's also infuriating. Let's say if a patient has obstructive sleep apnea or they have microalbuminuria, which is protein in the urine. Obstructive sleep apnea is a horrific sleeping disorder that essentially causes patients to not breathe in the middle of the night because their airway closes off. One of the top reasons for that is obesity. Why would you not allow your best version of these drugs to be covered all the time under the diagnosis code of obstructive sleep apnea to help with weight loss? Instead, what they do is they essentially just say, hey, we're going to act like that obstructive sleep apnea will cover this drug. But when they say, quote unquote, cover this drug for that diagnosis, that means they only may pay for it like 10%. Mm-hmm. So they're tricking you. They're going to act like that they're going to pay for it. The prescriber's going to get excited and prescribe it to the pharmacy. And then you're going to go to the pharmacy and owe $500 per month.
And guess who still gets that rebate?
So the PBMs still get that rebate off that Ozempic. And trust me, that big conglomerate that you're paying that copay to the pharmacy to, they're collecting on that too. Mm-hmm. It's all just a giant scam. Now, imagine this. You're working and you have 25 tasks to do that day. I'm exaggerating a little bit, but some PCPs see 25 patients a day. I see anywhere from 18 to about 20 or 21. I am getting a little bit busier in that regard. If I order 3 to 4 medications that's not on formulary, that means the following day I'm taking home 6 to 7 pages of paperwork times 4. Mm-hmm. And that's after I've seen the 20-ish patients a day that I have to chart on and follow up on labs. That's almost nearly impossible. Right. And I'm not trying to complain. That's not what I'm here to do. But I mean, at some point in time, and I'm willing to put in the work, physicians are going to get burned out. They're going to be human. They're going to say, you know what? 11 hours a day to this craft is enough.
Care suffers.
Yes. Now, I want to go back to you, Anthony, because I want you to talk about how this affects the providers on the pharmacy side, because this is actually what led to your pharmacy potentially, at least in part, probably closing.
I mean, I do want to talk about that a lot. Like I said before, my dad was a pharmacist. He's my hero, my mentor. He's the reason I do what I do.
He's a great man, by the way. We had a lot of fun.
So we were fortunate enough to open a pharmacy together. It was kind of our dream. We made it happen. And very quickly, we realized that it wasn't exactly a level playing. So the way that it kind of works, and it's much more nuanced than this, but in order to bill the PBMs, you have to sign a bunch of contracts. And the only way to tell when you're ready to go is that you keep submitting claims until one is picked. So we were up and running for a couple of weeks before we were actually able to bill insurance. So it was only cash prescription, people that were looking to take cash for stuff or buy it over the counter stuff. The first time we had a paid claim, somebody came in, filled our omeprazole. I'll never forget it was omeprazole. And a big red screen popped up saying that we were going to be reimbursed $5.77 under costs. I'll never forget that number. I can't remember the exact number paid, but it was $5.77. My dad and I looked at each other and we had to do something wrong here. So we reversed the claim, said it again, same thing, $5.77 under costs. And we then realized that this is kind of the norm. We got paid under cost a lot. You had to fill somebody's whole profile and hope that you made back enough money to cover it, or that you sold enough OTC or green cards to pay your bills, which isn't exactly why I went into this profession. But to take this further, my father, we were all the only two pharmacists there because, money was Ted doing this. As we were there, we're locked into a 5-year lease. Once we get it, we got to do it. So we're making it happen. It's us two. We have one full-time technician. My dad didn't even take a paycheck. I took a very modest one because I was just coming out of school. About 2.5 years in, he was diagnosed with cancer. He passed away 6 months later. It was only me and a per diem pharmacist at that point. I actually had to work the day after he passed away, which was a tough day. Every single patient that came to that pharmacy knew me and my father. We were the only two ones there. That's kind of why they came there. So I had the conversation 100 times that day, 100 different people, telling everybody that he had passed away, which was a very difficult time in my life. But I did keep it running for another 2 years. At that point, I was at the end of my lease. I made the difficult decision to shut the doors because I just didn't make it happen anymore. We were doing more and more prescription volume every year, but making less and less money and making it more difficult to keep the doors open. So at that point, I sold my file to Walgreens, closed my doors, and moved on with my career, which is tough because I know my dad wanted to do this to kind of set me up in the right way.
That's a tough one, man. I still will never forget that time in your life. And I know that in your heart, and just so for people, they understand, I know in your heart that you wanted to fight for that tooth and nail because of how much that meant to you. And to have something like that happen because of something like this is something that doesn't even make sense in this world.
Yeah.
And it's just really, really disappointing.
It's tough for me because, like I said, I know he wanted to set me up. And this was not exactly the way, we pictured it happening.
100%. Now, just to clear up one thing, because I do have one question. So when we talk about when you purchase the drug from the wholesaler, and then you get reimbursed for that same drug by the PBMs on the patient side, correct?
Mm-hmm.
And the PBMs definitely know what you're purchasing this drug from the wholesaler, correct?
Yes.
And they intentionally give you less, correct?
Mm-hmm.
Do the PBMs, the ones that are vertically integrated, the ones that own the pharmacies as well, the parent companies, do you think for that same drug, they reimburse more to those pharmacies?
They reimburse themselves. It's been shown over and over again. And even, like I said earlier, on the mail order aspect, if you get 90 omeprazole through the mail or you go to CVS down the street to get 90 omeprazole, those are billed completely different.
And we need everybody to understand that because that's how they're ruining their competition.
Yeah.
That's how they're becoming the bullies on the block, is that right there. You have to go through the PBMs to get your medication on formulary. I have no idea how that happened. That's just the way it is. Those same PBMs decide what each individual pharmacy gets reimbursed per medication, and they're reimbursing the independent, small business owner less. And they're reimbursing their big conglomerate, essentially same companies themselves, more. If that's not corruption that gets the common person fired up, I don't know what is.
I mean, it's so like you said, how much work you have to take home, just to keep up and really maintain good care. Working retail pharmacy now, because reimbursement is so bad, the only way to stay open is to, like I said before, fraud, which I would never advocate for, or these chain pharmacies push their pharmacists so hard that they just drive them right into the ground. In fact, 2 pharmacists from CVS in Lancaster, Pennsylvania committed suicide this past June. And a pharmacy technician in there also was found dead, but they haven't officially said what their cause of death was. There was a national pharmacist workforce study done in 2024, 198,000 pharmacists. 73% of the pharmacists rated their workload as high or excessively high. But 91% of pharmacists working at chain or mass merchandiser pharmacies reported workloads as high. 91%.
And these aren't, and by the way, just so everybody understands, I'm going to go on a little bit of a rant. I am going to sit on my high horse for a second. For anybody out there that is calling that soft, because our generation loves to use that term, I love to use that term. It would be like the equivalent of me calling a professional football player soft in terms of physicality.
Even if you think it's soft, it's going to cause mistakes. That could be you. That could be your child. There's going to be a prescription mistake that's going to kill somebody, and there already have been. So even if that's your opinion, you got to understand the public health crisis.
And I get all that, but the reason why I'm saying that is because these are people that have gotten the best grades in college, got through pharmacy school, passed their pharmacy boards, and they put in all that work and spent all that money into that extra schooling, and they're the ones saying, this is my dream job, and it's too much. We need to let that sink in. If 9 out of 10 pharmacists are saying that they're being overworked, that's a huge problem because they're the people directly giving you, like you said, your medication. It's a huge problem. That's not something that you should be manipulated by the big media companies as saying that we're just so whiny babies. Which, by the way, the big media companies have done that successfully.
Absolutely.
They have portrayed pharmacists and physicians as whiny babies that don't want to do work. I promise you, pharmacists and physicians statistically are some of the hardest working people in this country just by definition. They got through undergrad at an elite level. They got through medical school and pharmacy school at an elite level. They had additional training in residency and then also maybe in a clinical pharmacy residency as well. Some of them are their own business owners. But the crazy part is after you go through all that, if you want to be your own business owner, the deck is so stacked against you.
Right.
You got no chance. You essentially, at that point, have to sell your soul to the devil. That is an exaggeration, but it's essentially what it is, especially on the pharmacy side. But I think it's coming for the physicians, by the way.
I think it is. I mean, it's the same companies, like you said, they're looking for more to eat, man. That they're not done. That's not how this works.
So, with that being said, let's try to just bring this back in because, yes, we're here to talk about the injustices in medicine. That's what Guardia Di Medicina is all about. That was my dream when we started this podcast. What can we do as me and you to make this better, number one? What can the collective we do to make this better? And then if we had a magic wand, what would we do if we had the opportunity to change the system to make this better? I'll let you start.
So I think, on a personal level, just raise awareness about what PBMs are and what they do. I've been doing that I've been a pharmacist for 10 years, really since I understood exactly what happened behind closed doors, how things are built. I've been trying to raise awareness. So I think that's a big thing. Getting involved when we can to help explain to a bigger audience of what's happening. It's hard to say exactly what I would do if I could wave a magic wand. A lot of pharmacists specifically advocate for like flat dispensing fee. And, I think no matter what, there's going to be somebody that tries to commit fraud or somebody that begins a little bit too much money in the system. But I am much more happy if that's a patient getting more money in their pocket or if that's, a pharmacist who doesn't commit suicide because they have to fill 800 prescriptions in a day and they have no technicians and their district leaders threatening their job. And, I'm okay if somebody makes a little bit more money. So these middlemen who literally don't do any. The full reason they're there, I want to emphasize, is to control drug costs. And the FTC is found in a lawsuit. They literally make things more expensive. So it's hard to say exactly what I would do because the system is so screwed up now. But on my end, if we could do a flat cost plus X dispensing fee, I think that would help out a lot more because then you at least have a predictable reimbursement. And again, sometimes you get medications for cheaper, but in my opinion, if I'm spending the time to shop around and find some medications that, maybe this wholesaler bought too much of this and then trying to offload it, if I'm doing that, why does that have to be the baseline medication? That I should be able to make a little bit extra money smart shopping. I shouldn't have to smart shop just to be able to keep the lights on.
Starting off first with what I would do, just me as a person, this is it. I mean, we're sitting here in a podcast studio, both after work, when we could be doing other stuff. Obviously this is fun for me. I'm enjoying talking about these kind of topics, but this is it. This is me trying to raise awareness about different things that I think are injustice of medicine. And I'm hoping that when you get enough conversation, enough people on board, the tide eventually turns. We've seen it happen. We've seen it happen in politics when enough of the common people get angry, that eventually the tide turns. That's the only way that I know how to do it. It's trying to start a conversation. Will we be successful? I don't know. Maybe, maybe not. But at least we say that we tried. If I had a magic wand, it's all about competition. We always talk about capitalism. And capitalism works great, but not when it's fake capitalism. Not when it's a controlled market. This is a controlled market. We got 3 companies, each of them about 26.5% of the market. You put them together, that's 80%. We need the max amount that a company should be in charge of this type of market because it's so imperative that we have equal prices, 5%.
Capitalism is great, but there have to be guardrails. If unregulated capitalism led to monopoly, 100%. Quickly realized it's not okay. So we threw some guardrails. I'm all for capitalism, but there needs to be appropriate guardrails.
And I think that if they made some law that a PBM can only own 5% of the market share, I think PBMs could actually do their job effectively because then guess what? That means that the manufacturer can shop around. Mm-hmm. I also think this vertical integration's got to go.
In any other sector, this is no go. You can't, what is it, to start the anti-kickback law?
I can't do anything. I can't even refer to something. Let's say if I own a home health industry, I'm not even allowed to refer to that home health industry. That'll have to be completely standalone. In my practice as a family medicine doc, could not even interact with that home health agency. So why are these PBMs also allowed to own the pharmacy that they're working with directly and the insurance company that they're working with directly?
Not only are they allowed to own it, they're allowed to tell you can't go anywhere else. It's just like if you had a home health agency that said you can't go anywhere.
I'm either going to fire you as a patient or you're going to go and you're going to go get your treatment from this.
Yep, even though I'm not a physical therapist, I'm going to tell you what treatment they're going to be able to do.
That is the opposite of freedom. That is the opposite of what the United States stands for, and that's the opposite of why I got into healthcare. Just straight up. So I would say those are the 2 things. Now, why that's probably not going to happen? The lobbyists. We either need to get lucky and elect somebody that already is super rich and has outstanding morals and doesn't pay attention to lobbyists and doesn't care if they get assassinated. And we need to elect 50 of those at the same time for this to change. Or we need to change the laws. That's it. And we don't have any control over that. The only way that we do is if we talk, and enough people get angry about it that the government cannot ignore it any longer. We've seen it happen a few times. It's happening right now, in my opinion, with some of the things going on in the Middle East. The tide is clearly turning, but that's what we need to happen.
So I would urge people also to look at the candidates they vote for and where they receive lobbying dollars. It's usually there are layers to it, so it's kind of hard. But I believe PCMA is the biggest PBM lobbying group. I'm sure there are other ones. I don't know off the top of my head who they donate to the most, but I can tell you that I would look at that list and that would be a list of politicians that I do not trust.
Especially when it comes to medicine.
Yeah.
I mean, any politician that's willing to accept money to sell out their own constituents' health care, by definition, they're already not doing what they're supposed to be doing.
Yeah. So pay attention how people are voting on PBM reform, because there are bills that come through once in a while, and make that impact how you vote.
And then one last thing when we talk about just voting in general, I know we're kind of getting off topic here, but this is fun. We talked about earlier is why don't the American people know about PBMs? Why don't they understand what that is? Well, it's because they got us talking about, for example, just random political issues. They got us talking about abortion for the last, 60, 70 years. It's just nonstop.
Trans kids in sports.
They got us talking about gay marriage for the last, 60, 70 years. They got us talking about racially, profiling each other. They got us talking about immigration. They got us talking about the same stuff over and over and over again. So that way we argue with each other rather than talking about these types of things that make the whole system money.
And you forget you're getting screwed when somebody's waving their middle finger, and that's exactly you stop paying attention to other things because you're getting outraged. The person waving their middle finger.
100%. Do you have anything else that was on your mind that you want to talk about in terms of data?
I think I covered just about all the numbers that I wanted to. I don't think there's anything else that's as wild as that we mentioned. I think that people need to understand what PBMs are. They need to see this problem because it's affecting you in so many ways, even if you don't think it's. You could be that person that gets a misfill, or your child could be that person that gets a misfill and it gets hurt because the pharmacist is quoting so many directions that they're just trying to get through the day. That's not why I got into this. I didn't get into this to be a vending machine. I want to do clinical work. I want to help people. I want to help people understand their therapy. So that's what I like to do. So this is a berry.
100%. And one last word about these big three parent companies. And we kind of see this throughout the world, in my opinion, as well. And I'll get to that example in a second. The more that these big three companies generate an umbrella under multiple different sects of medicine, different sectors of medicine, the easier it's going to be for them to turn every single patient into an avatar, into a number. We already see it a little bit with the whole world, where there's this conspiracy theory that we're all under one government and where we all are getting surveilled on our phones. They're trying to do the same thing to us in medicine. They're trying to put us all into one giant pot and say, hey, this person's got disease X, they're going to get medication Y, and we're going to make Z amount of dollars every single time. That's their goal.
Yeah, it's frightening.
Well, with that, I think that's the end of our first episode, my man. Hey, everybody, this is Guardia Di Medicina.
Thanks for tuning in.
I hope you tune in next time.
See ya.